Thank you for joining us, for joining me tonight for this Q&A session. The title is "What to Do When You're Trying to Conceive," and please post as many questions as you can. I'll obviously try to answer as many as I can tonight to help you with your questions. I guess so I should introduce myself. My name is Robert Lahoud. I'm a reproductive endocrinologist, and currently I work as the clinical director at IVF Australia North Shore. I've been doing this for about 20 years, and I must say the last few months have been very challenging. I think for all of us it has been. With COVID-19, you may have heard that we had to shut down IVF service for about a month, but the good news is things are back up and running, and all the news about the virus, because we've kept it under control so well here in Australia. We've been really lucky, so that's fabulous, and we've got a really busy egg collection list coming up on Friday. I guess it gave me some time to reflect back on what I've learned over the last 20 years too, and certainly from a fertility point of view, I think one of the things that's really important to understand is that fertility is complicated. There's so many factors that have to line up to make a baby, and it's no wonder that often it takes a few goes to kind of get there. So today we're going to talk about what we can do to make that happen, and obviously happy to answer any questions that you've got. I think that what is really important when you go through the journey of trying to conceive, that there's so much information out there, and not all of it is really good. And so I think having a understanding of the complexity of fertility is really good. Having gaining knowledge about why things may or may not be happening, and to have an honest understanding of what's really happening really helps you to get through this. I think as fertility specialists, we are really, really lucky that we can be part of that journey with you guys for a little bit of time, and obviously hope that it ends up in a successful baby. But even if not, I think just getting through that stress of not being able to know what's happening is really important. So look, and I think at the end of the day, having that understanding helps you to persist, because the biggest thing that you can do is keep trying till you get there and not give up. And so I often say to my patients, if you know it's a marathon, you know how long you got to pace yourself for, whereas it's a sprint. You got to know what you're in for, so that you know what you need to do. So look, I think we've got our first questions, and there's a question here from Violet, who's asking how long before the first embryo should you be starting to take your prenatal supplements. Now, prenatal supplements are mainly for the baby, and so at least probably I would say a month or so before it's ideal to start taking the prenatals. But if that was not possible, even 2 or 3 weeks will have some benefit. The original studies actually said 3 months, and it's mainly folic acid that was found to be beneficial. But in reality, if you have a good diet and you start taking them even a week or two before you start your IVF cycle, that would be good. The second question comes from Alicia. How long can I take melatonin for to improve egg quality, and what is the dosage? So melatonin is normally used in the evening. Melatonin is a hormone that the body makes when it gets dark, and it has an antioxidant effect. So some people use it for jet lag or help them sleep. It's not really a sleeping tablet. It is a medication people take for that reason, to help them sleep. But it also has an antioxidant effect. This is not totally proven yet, but it may have some benefit for the egg quality. I normally get people to start it maybe 2 or 3 weeks before they start their IVF cycle, but there's really no right or wrong. Like, even if you took it 2 weeks before the egg collection, and when you start the injections, that would be okay too. The dosage, I think, should be somewhere between 5 and 10 milligrams. And I'd be careful about not buying melatonin without a dosage on it. So there's some chemists that sell melatonin which has got nothing written on it, and I think there's probably nothing in there. If you go overseas, like when I used to go to the US, often 10 milligrams you can just buy over the counter. So somewhere between 5 and 10 milligrams would be my suggestion. If you can't get that over the counter, you can actually get a prescription from us doctors, and you can take it to a compounding chemist. So 5 to 10 milligrams starting at least with the injections, maybe 2 or 3 weeks before you start your IVF. I've got another question here from Emma. It says, "Hi doctor, is it safer to take folate instead of folic acid?" Just in case I have MTHFR mutation. What prenatal do you recommend? So I think folate and folic acid in many ways are very, very similar. The MTHFR gene mutation, just for anyone that doesn't know what this is, it's a gene mutation which is very, very common. And with all gene mutation, you can either carry one or two genes. It's got a very slight link to blood clotting, so higher risk of blood clotting, and it may have a link to causing miscarriage, but this is still a debatable sort of thing. But the way you treat it is by using high dose folic acid. So often, instead of taking the standard folic acid that you would use in a prenatal like Elevit, we would normally use something like Megafol, which is 10 times the dose of folic acid, so it's 5 milligrams. But we only do that when you actually do have the mutation. So in general, I think something like Elevit or any other prenatal that's got at least 500 micrograms of folic acid should suffice. And generally that will work. The diet is really important. Green leafy vegetables are a fantastic source of folic acid, so we shouldn't ignore that either. So a lot of us who live in Australia have a healthy diet, probably don't even need to take folic acid, but if you ask me what to take, yes, somewhere between 500 and 800 micrograms of folic acid. And if you do have the mutation, the MTHFR mutation, then go to 5 milligrams, which is 10 times the dose. We have another question here from Tiffany. Hi, Robert. Michael and Tiffany saw me. Okay, sorry. It says that you conceived a baby girl, 28 weeks now. So thank you. So that's really nice to get this message. With my low MH and only surviving 3 embryos out of the 3 eggs. She's so healthy and beautiful. So when she's born, and it goes on. Look, thank you so much, Tiffany, for sending me a message tonight. And especially in these times when things are so difficult, it's always nice to get some good news. And look, it shows also that even those patients that have a low AMH where there's not a lot of eggs, we can still get good quality and achieve success. So I'm really grateful for the message, and I hope you guys keep well, and not long to go. So all the best for you guys. Moving on to the next patient, and thank you again. This is Kathleen, and she says that we helped her to have, or I helped her to have first baby, and this was 11 months ago, and thinking of giving it another go, which is fantastic. And the question here is really, does a cesarean section make it harder to conceive? And how long do you have to wait for do you try again? So with the cesarean section, obviously most of you know that sometimes the baby can't come out vaginally, and then you need to do a cesarean section. The scar often needs a few months to heal, and your obstetrician or the hospital will give you some idea how long they think that should be. Generally within 3 to 6 months, the uterus should have healed up nicely, and it's okay to have another baby at that stage. So I think anytime after that time, it's okay to kind of look at conceiving again. A lot of our patients come back somewhere between 6 and 12 months when they've had a bit of time to get used to having a baby, which can be really stressful, obviously, at times. So yeah, definitely. So yeah, Kathleen, come back and see us when you're ready, and it should be okay. The cesarean section scar should have healed up really, really well. I've got another question here. This is from Kath, who has a low AMH. Is DHEA proven to improve egg quality? Now, DHEA is a adrenal gland androgen. It's a very mild androgen. Androgens are testosterone-like preparations, and DHEA has been used for quite some time to help women with low AMH to produce more eggs, maybe better quality eggs when you're doing IVF. And look, there's some proof towards that. It still remains to be totally shown. I think with a lot of these medications, they work for some but not for everyone. That's why it's hard to show a huge benefit when you're doing studies. But I think it's definitely a reasonable thing to take, and you should always check with your doctor or whoever's looking after you whether that's the right thing to do. And generally we take somewhere between 50 to 75 milligrams a day. At that dose there should be minimal side effects, but if there's any, again, check with the person that's prescribed that for you. So yes, I think DHEA may help improve the egg quality and egg quantity when you're doing IVF. And this is mainly for women who have a low AMH or low ovarian reserve. So really good question. Vicky, Vicky's asking a question here. How long do you suggest to try naturally before IVF if all tests come back clear and no issues with fertility and so on? I'm trying for my first baby. So this is a really important question. How long do you try before you do IVF? And this really depends on several factors. One is the age. The age of the woman particularly is really important. So in women over the age of 35, especially over the age of 40, we recommend not to wait too long. So maybe 6 months, it would be good to come and see one of us fertility specialists to have a chat about what the options are and what the chances are. And in younger women, I think it's probably okay to try for 12 months, as long as there's no obvious problem. If there's a problem with the periods and they're regular, if the sperm test is poor, if there's something else that clearly in the history that if someone's had bad infections of the tubes before, then they should really see one of us earlier, because they may need help quicker and they may be losing time at home. So generally we would say after 35, especially after 40, then 6 months. Before that, 12 months, okay, if everything is okay. Really good question. The next question comes from Philippa, and here's a question also about DHEA and CoQ10 leading up to IVF. And I'm not sure what the question, so I presume the question is that is this a good thing to do? So DHEA we talked about, and it may help the egg numbers, egg quality, especially in women with a low AMH and low ovarian reserve. CoQ10 is a really, really good antioxidant treatment, so it works on the quality of the eggs, and it's something we're using more and more. Much of the evidence on CoQ10 comes from other studies looking at preventing metabolic diseases like heart disease, and it's being used a lot. And again, like a lot of these things, they're obviously fairly mild treatment that improve our health. And I think in IVF, it does help some people to improve the egg quality, but not everyone. But it's very benign. It doesn't cause any side effects. So I think it's a good thing to take, and we are using it more and more. But if you said to me, look, is there absolute proof that in someone doing their first IVF cycle, this will make them produce more eggs or better eggs? There isn't. But again, a lot of people use it, and I don't think there's anything wrong with that from my point of view. We've got another question here from Violet. This is about, I'll just read the question. I'm about to start a Proganova cycle before the transfer, and I don't understand exactly how it works. I'm also concerned about progesterone for so long, and I might need to read a bit more. Should I be concerned? Will it mess my emotions? So Proganova is a form of estrogen, and we're mainly using it in what we call HRT cycles for frozen embryos, but use maybe a different cycle. I'm not 100% sure. And what it's meant to do is prepare the lining of the uterus. We check that with an ultrasound. Once the lining is good enough, we then start the progesterone. And look, you can be on Proganova for quite some time, obviously 2, 3, 4 weeks. Anything beyond it, I would probably say best to stop and restart. Prolonged unopposed estrogen is not good for you. So, but yeah, if it takes a little bit longer, and you said that the COVID situation, you had to stop and start again, which I understand makes life difficult. But it should be okay. If it's not longer than 3 or 4 weeks, it should be okay. The next question comes from Rainbow. So thank you, Rainbow, for sending your message. Is there any harm in taking prednisolone while pregnant and taking doxycycline? Now, prednisolone is a oral form of steroids, so you take it as a tablet every day, and there's many uses for that. Obviously, there may be medical reasons like having asthma or arthritis that needs steroid treatment. We sometimes use it in patients who have immune problems where the immune system may cause rejection of the embryos, and we may sometimes measure this with the natural killer cells. So prednisolone can have negative effects in pregnancy. So in the baby, there's a slightly higher risk of cleft lip or palate. So cleft lip is where the lip and the palate doesn't form, and that can obviously be fixed, but still it's and the risk is normally 1 in 1,000. When you're taking prednisolone, it goes to 3 in 1,000. Later use of steroids may also have some effects on brain development in very high dosages, and And there's also this structure near the heart called the ductus arteriosus, which may stay open, which may cause some problems with breathing at birth. Um, so steroids do have some side effects, but look, generally they are very, very benign, and these effects are still very, very low. The immediate effects for the woman include weight gain over time, getting really, really puffy. Long term, there's a risk of diabetes and osteoporosis, and short term, also people may get palpitations and anxiety and finding it hard to sleep. So it's always important to be careful with using this, and also with the COVID around at the moment. We don't quite know whether suppressing your immune system with something like prednisolone is potentially harmful. So look, check with your doctor, see what they say. But yeah, no, it certainly can be harmful, but at the same time, it may also be helpful. So best to check with whoever's looking after you what they think is the best thing for you to do. Moving on to the next question. There's a question here from Renee. Natural killer cells are still a thing, question mark. Wondering if I found a donor for eggs is 40 to 45 too old. I also have endometriosis. So I guess a couple of questions here. Natural killer cells, which we do test in the blood and in the endometrium, are meant to be a mark of an overactive immune system. And when it comes to falling pregnant, you've got an embryo that is different genetically to you as the woman who carries the baby. And for the uterus not to reject that embryo, the immune system has to adapt, which is quite unique. If you put my kidney into you, you'll reject it unless I give you some medications. And so the theory is that for most people, their body does accept an embryo, even if it is slightly different genetically, because of the sperm and egg being there together. But maybe in some the people that immune system doesn't work and it rejects the embryos. And if that's the case, you should maybe try to dampen the immune system, and that's why we do use steroids. Now, the proof for that is still very, very controversial, and if you asked 10 of us fertility specialists, 5 would say, don't use anything, don't even test, and the other 5 would say, yeah, look, it's okay, and there may be 1 or 2 that'll say, look, this is the panacea of fertility, and it probably isn't. But look, I think it's still a thing, and nothing much has changed over the years. When it comes to egg donation, there is no age. Well, so we do have an age limit at IVF Australia, which is 50. So if a woman is over 50, we would not want to treat her with donor eggs. So 40 to 45 is certainly fine. And endometriosis, when it comes to IVF, it doesn't seem to have much of an impact. So the implantation rate should still be good. And the success really comes down to the age of the donor, which is always comes back to that fact that the younger the egg is, the higher the chance of conception. So look, there's definitely some opportunities there for you, Renee, and definitely if you want to have another chat about the natural killer cells, it's something we debate a lot. I've got another question here from Beck, and oh shit, that's a message to me. So thank you, Beck. Hi. Nice to talk, and yeah, it's brilliant to hear from you too, and hopefully you're staying well in these sort of challenging times, and nice to see that all is well at home. I hope you're getting lots of rest too with the baby. Now we're going to go back a bit further, and I've got a question here from Donna. Like, I'm just trying to see. Okay, no, that's good. Look, it's a message directly to me. So, yeah, look, nice to talk, and I can even give you a call a bit later, but definitely exciting. We're not far away from collecting those eggs for you. So looking forward to catching up and very, very soon. Excellent. Look, and moving on to, I think, our next question. So this is from Jenna. Jenna's asking, what is the youngest age IVF Australia see? Would a doctor send a referral through for someone in the early 20s? And the answer is, look, we would, if obviously that's necessary. So probably the early 20s is the earliest time we see patients, and admittedly most of our patients are over 35 and probably over 40. But obviously if there's a significant problem, we do treat younger patients, and the main reasons for needing help really early on is male factor, where the partner has really, really low sperm counts. younger women also often have polycystic ovary syndrome, where the periods are irregular and people are not ovulating. And even though we tried to treat women with PCOS with letrozole and other medications, which are very, very effective, if this doesn't succeed, sometimes we move on to IVF. And young patients have fabulous chances of conceiving because often the eggs are so good, and IVF works really well. But obviously, IVF is generally not our first option. It's when everything else has failed, especially in the younger patient. But yeah, definitely look, if you need help, definitely contact us. We have the IVF Australia 1-800 number. If you contact us, we'll definitely be happy to look after you if there's an issue. Obviously, the beauty about being younger is there's often a little bit more time, but if things are not happening, then there's nothing wrong with coming to see one of us. And anyone that's younger, that's taking more than a year to fall pregnant, that's actually really unusual, where this is much more common in an older woman. Hence, yeah, definitely worthwhile coming to chat to us. And maybe it's just a simple thing we can help you with, that will get you there. Now, I've got another question here from Lisa. How long should I wait until the first baby to defrost our second one if you're 35? So this is a question like, after you've had a baby from a fresh or frozen embryo, how long do you wait for a frozen embryo cycle? So at the age of 35, obviously we say it's best not to wait too long. So most of my patients, I would say, look, maybe wait 6 to 12 months. If everything is good, the family's settled and you're ready to go, then come back. And frozen embryo cycles are generally ever so easy in that they have a very good success rate, usually close to 50% per embryo. So whenever you're ready, definitely come and see one of fertility specialists so we can plan the frozen cycle for you. Obviously, sometimes people have a tough time at home with the baby, and then obviously when you're ready, but enjoy those first 6 to 12 months with the baby, because it's precious time, especially when you've worked so hard to get there, sort of thing. But yeah, 6 to 12 months is very, very reasonable. The next question is from Kath. Thank you, Kath, for your question there. What is the recommended dose for CoQ10 or Ubiquinol? So I mainly use CoQ10. We recommend about 300 milligrams a day, but a lot of the preparations come as 150 milligrams. And some people use 350 milligrams to make it 450 milligrams. So that's the dose. I normally use 300 milligrams of CoQ10, and you can get that in a single high dose tablet. But there's no right or wrong with that, because, as I said before, none of these things have been clearly proven. But that's what we use, and like I said, it may help to make the quality of the eggs better. It's a strong antioxidant treatment. Now, next question comes from Emma, and thank you for bringing these questions. This is actually a reply to Jenna. It says, I was 20 when I went through IVF Australia and to have my son. So thank you, Emma. That's really, really good feedback. It's good to know. And I'm sure Gemma won't feel bad about seeking help, even though she's young. At the end of the day, look, it can happen to all of us at any stage. And if it's not happening at home, then this is a great thing. And when you're young, you have such good success rates, which really helps. I'll move on to the next question. And thank you for sending all these questions. So this is from Nicola. Nicola is 42 and her embryos are 38, so I presume they're made 4 years ago. She has 10 of them, which is fabulous. That's a huge number. She says she has got a interactive thyroid and type 2 diabetes, maybe some underactive thyroid, but and she's using Trulicity injections weekly for her diabetes. My blood shows that I'm perfectly ready to go forward now with IVF and being for frozen embryo cycle. What are the stats? And once I get transfer, should I store more embryos now before starting IVF? Okay, so look, obviously it's a good question to even speak to your specialist exactly. But look, generally an embryo made at the age of 38, if it's a frozen blastocyst, it's got about a 40% chance, maybe even up to 50% chance of taking. If you've got 10, that's a really, really good batch. And I think that's enough to kind of use over time. Look, it's very likely that you should be able to have a baby or two. And if your diabetes and everything is controlled well, then this is as good a time as any I think, to do this, as long as obviously a specialist agrees with that. Um, Making embryos now at 42, which is 4 years down the track, is not going to be quite as easy, and the quality of those embryos will be less, and the pregnancy rate will be less. So having 10 embryos that made at the age of 30 is absolutely fabulous. So I think my advice would be start using them first. But again, look at, I don't know exactly the quality of those embryos, so it'd be good to discuss that with whoever made them for you. So hopefully that helps with making up some decisions for you. But absolutely, it's fabulous. That's a great number to get that many good embryos. So this is a question whether I work in Brisbane. No, unfortunately not. And so this is from Crystal. I'm in Sydney. I work on the North Shore at Greenwich at our big clinic, and I also work in Wahroonga and Ekasi in the northwest of Sydney. But we can, if you need any advice or second opinion, then we do Zoom consults now, especially with the COVID, so where we can meet like this online, and we've got a clinic in Brisbane, which is called QFG, or Queensland Fertility Group, and there's some really good doctors there. So if you need any help, like our hotline, the IVF Australia hotline, will be happy to help you find someone there. But look, happy to do a Zoom consult if you need any help, and obviously refer you on to the doctors in Brisbane too. So thank you very much for the question. Next question comes from, and sorry, my eyesight is not very good, but I think it looks like Titik. Hi, Doc. Just a bit curious about how long the processing starts from egg collection to embryo transfer, and which is better, frozen embryo or fresh embryos. I'm 37 years of age, and from the HSG, one of the tubes was blocked, and the other problem is sperm quality. And then it goes on to say, which wasn't so good. Planning to do IVF this year as soon as the pandemic is gone. So this is a really important question. So when you're doing IVF, they're fresh and frozen embryos, and there's been a lot of research into what is better. Now, 20 years ago, fresh was definitely better than frozen because our techniques were not good and the embryos would not survive. Now, fresh and frozen is pretty much the same. But in women who have a lot of eggs, who overstimulate, especially we normally have more than 20 eggs, there's clear evidence that freezing gives you less risk of hyperstimulation when you have so many eggs that your ovaries are really large, uncomfortable. By freezing the embryos, we don't allow the patient to fall pregnant. We allow them to recover because the pregnancy hormone makes the hyperstimulation worse. So this is a definite benefit to the patient. And studies have shown that babies born in women who have lots of eggs, if they're born from frozen cycles at birth, are a little bit bigger. So the suggestion is that the placenta is stronger and better. So there may be some health benefit to the babies by having been frozen, that scenario. Now, that is not clearly shown yet, and it's only suggestion. So probably we would say that if you get a lot of eggs, then to freeze all the embryos and put them in a frozen cycle is probably the way to go. If, on the other hand, there's not too many eggs, it's under 10 or 12, or the patient's feeling totally fine, then it's fine to do a fresh embryo transfer. And that's what the studies have shown. That then there is no difference with the placenta, the birth weight, or the success rates. So it's only in those women who have a lot of eggs where this is the case. And normally we wait 5 days from the time we collect the eggs before we transfer them or freeze them. At that stage, they're called blastocysts. And those embryos can be put in fresh or frozen. They work really, really well. And obviously, it's always the hard thing to get the embryos to there because some patients don't have the same quality that others do. But hopefully, that's the case for you, that you'll have lovely embryos and the doctor can choose to either do fresh or frozen. And that's my answer. Is basically, if you have a lot of eggs, go for frozen. If you have a few, then either one is fine. I'll move on to the next question. This is from Benazir, who's asking me, I'll read the question. I have my FET, or frozen embryo transfer cycle, on Monday, and I have been on Proganova. We'll start on pessaries from this evening. On my last scan, the nurse didn't check for follicles. Is that not important to check before an egg transfer, an embryo transfer? So here we're talking about a frozen cycle where we're using estrogen to prepare the lining, and then we're using progesterone, which is the pessaries, before the transfer. And look, in general, when you use estrogen and progesterone together, it stops ovulation, so there should not be any follicles. And what we normally do is we do a blood test to make sure that the progesterone is not risen before we start the pessaries, because if the progesterone is high before the pessaries start, like today for you, then that may make the timing for the transfer inaccurate, and that is less likely to work. So in general, if follicles aren't that important, as long as the blood test is okay, that would be my answer. But yeah, look, it's always good to check for follicles, but in general, even if there's a follicle, it doesn't really make any difference, because it's not likely to lead to ovulation. It's not likely to lead to progesterone prior to you starting on the pessary. So maybe check with them that they've done a blood test at least to check for progesterone. If that's okay, then you should be fine. Yeah, look, moving on to the next question. Another thank you. So thank you very much for Christina. Really good to hear that's all going well, and hopefully we'll catch up again soon. And I've got another question here from Rainbow. So thank you for joining us tonight. What are the chances of a grade A blastocyst, and we normally call them A, B, C, that will be PGD normal or PGS? So this is tested for chromosome abnormalities. Thank you. So here what we're talking about is an embryo that's reached the blastocyst stage. It's A grade, so it's a really nice embryo, and we have taken some samples from the embryos themselves to test to see if it's chromosomally abnormal. We call this PGT nowadays, so pre-implantation genetic testing, and we're looking for chromosome issues in the embryos. And as women get older and older, there's more and more chromosomally abnormal embryos. So knowing that this embryo is normal will really help. So generally, when we look at our data across all ages, whether you're 35 or 40, the average pregnancy rate we're getting is about 50%, which is really good. Obviously, every unit is a little bit different, and so it's important to check what the rates your unit is quoting. But generally, 50% for a PGD embryo is good. It's fantastic. And the good thing is, even a woman at 40 or 42 that gets a normal embryo will have a good chance. Now, I'm not sure, I've lost my video here, but I think we're getting towards the end of our time. Now, no problem. I'm not sure why I've lost the video, but I can still answer your questions, which is no problem at all. So I've got a question here from Catherine. So Catherine here is asking, are there key studies or guidelines on how much laparoscopy to remove superficial endometriosis improves IVF success rates, frozen embryo transfer success rate? Again, a really, really good question. So most of you that know what endometriosis is endometriosis where the lining of the uterus or the endometrium grows on the outside of the uterus around the uterus and underneath the uterus. This can reduce natural pregnancy rates, but when it comes to IVF, it doesn't seem to have much impact. So doing surgery prior to doing IVF, probably at the moment the evidence is that it really makes little difference, especially if it's superficial, and it probably doesn't help with frozen embryos either. So if you ask me, do you need to do a laparoscopy before you do IVF? I would say no. There may be some occasional circumstances where that's the case. But look, so that would be my answer to that. Look, I might have a couple of questions. Anything I can obviously answer later, be happy to do so. And thank you for sending all these really great questions. It's really good to be able to discuss it with all of you tonight. So here's a question from Julia. Julia's asking about implantation failure. So the question is, Doctor, what are your thoughts about implantation failure and options available to explore? Now, this is a really important and difficult subject. So when it comes to implantation failure, what we're really talking about is putting embryos back in and they're not implanting. How many embryos you put in is debatable. We said if you've put 3 embryos in and the patient is not pregnant, then we want to do some further tests to see what's happening. And to have one or two not take is pretty normal. It's just part of IVF. And with regard to testing at that stage, there's a whole lot of things. We look at the uterus in detail. We may look for immune things like the natural killer cells that we talked about. We may look at the sperm in more detail, maybe look at the eggs. And once we've looked at that, we may have a slightly different way of treating people. At the end of the day, implantation failure is a normal part of IVF, even though it sounds a bit defeatist. It's true, and it's really important to understand that. That doesn't mean we can't get there. But yeah, obviously, implantation failure, it's really important to look at every part, from the egg, the sperm, to the embryo, the uterus, the immune system, everything. Look at all the potential reasons, investigate them thoroughly, and then come up with a plan. And hopefully, by making some little changes, we get there. And the main thing, like I said right at the beginning, is often just about persistence, and persistence is what gets you there. Now, I might ask one more question here from Tanya. I know weight is a factor. I have PCOS and I've tried everything and failed for the last 10 years. I'm now 33 and I've been told my BMI is too high and I need to get below 30 to be considered for IVF. Is that true? Okay, this is a really important question, something I feel quite passionate about, because I do see a lot of women with PCOS, and a lot of women with PCOS, but not all, are overweight. And look, in general, my attitude is that there's only so much we can do, but I think we should do the best we can. And that would involve like a really good diet with regular meals and watching what one eats. Especially with PCOS, it's important to avoid high carbohydrate foods, foods that are high in GI, like sugary things. Have regular meals, and also to exercise a lot to be quite fit. And if you do that and your weight doesn't shift much, I think that's okay. Because it's really hard for someone with a BMI that's 35 to say, look, you've got to go to 30. That's a huge change. I don't believe that massive weight loss by taking medications, just appetite suppressants or anything like that, is really healthy for you in the short term. And there's studies to show that that may not be the way to go. You may need to stabilize at the lower level before you can even fall pregnant. And so look, that would be generally my attitude, is do the best you can. If your BMI doesn't shift much, you can still do IVF. Obviously, if it's a really major problem and it becomes impossible to do IVF, or the IVF doesn't work, then there are some options, even to the extent of bariatric surgery, which in itself is quite a major thing to do. And once you've had that, then you're meant to kind of wait a year before you're allowed to fall pregnant to stabilize things. So look, in general, do the best thing you can. Then you're probably fit for pregnancy, and you should be able to do IVF. That's kind of the attitude we normally have. And look, I might answer just one more question. I hope you can see me, because I have a problem with my camera, but this is all good. This is a question from Fiona. Does adenomyosis reduce implantation rate? And are there any recommended treatments for adenomyosis? And this is another really, really good question. So what is adenomyosis? Adenomyosis is where the lining of the endometrium grows deep into the muscle. And this causes pain, a lot of period pain. It may also cause heavy periods. And this is not uncommon. A lot of women have this, probably about 10% of women. It's normally diagnosed on ultrasound, and MRI is a good way of diagnosing it. Now, does it reduce implantation rate? Look, it may, and it may not. There's two schools of thought. The Americans strongly believe that adenomyosis may reduce implantation rates. We've done a study in our unit at IVF Australia. It was Michael Costello with Juliet Koch, and we looked at frozen embryos with or without adenomyosis, and we found no difference. So look, we don't know whether it definitely reduces chances with IVF. It is very difficult to treat, and the treatment is either surgical, where you have to cut open the uterus and remove this deep endometrium, which causes probably a huge amount of scarring. It's very risky. Or you can do it with radiological methods, where they try to embolize, so they put little seedlings into the blood vessels around the adenomyosis to shrink it down. And look, both these things are potentially very dangerous. So I would normally say not to worry about the adenomyosis, leave it as it is. go ahead with your IVF. The other thing to say, there is a strong link between adenomyosis and endometriosis we talked about before, where the endometrium, this endometrial bacteria, is not inside the uterus, but on the outside uterus, on the ovaries and whatever. And like that's maybe something worth investigating too, if that's there. But look, either way for IVF, it doesn't potentially make that much difference. But look, there's certainly some people out there who believe that adenomyosis may reduce implantation, and still something that's hotly debated in our field. I think I've, yeah, look, thank you so much for all your questions tonight. And if there's a few more, look, please give us a ring on our 1-800 number so that we can answer those for you. Look, thank you so much for listening. Really a great pleasure to answer some questions for you guys, especially in these sort of difficult times. Like I say, if we can help at all, yeah, send us a message or ring the 1-800 number. And yeah, thank you so much for listening tonight. And hopefully we might see you even in the surgery one day. All the best. Bye bye.